Okay, so welcome to this next video in which we are discussing the pathology of rheumatoid arthritis. Okay, so we've seen that in the pathology of rheumatoid arthritis we start off with this pre-articular phase where we produce antibodies which are targeted against citrullinated proteins. So there are a huge great number of citrullinated proteins that you can produce. Now some of them end up with antibodies produced against them, and we group all of these different antibodies which target different citrullinated proteins together under the umbrella title anti-citrullinated protein antibodies. Okay, right. So, what then happens is this doesn't cause any problems for a long time. At least it doesn't cause any problems on the level of the joints. However, you then start making an anti-citrullinated protein antibody which is targeted against fibrinogen. Okay, specifically citrullinated fibrinogen. So you make an antibody which will bind to citrullinated fibrinogen. Now you have citrullinated fibrinogen within your blood. Okay, so what happens is you get these immune complexes where you have the antibody bound to its citrullinated fibrinogen within the blood. Now what then follows is that you get some sort of injury to one of your synovial joints, okay, some sort of injury, maybe a microbial insult, maybe a mechanical insult, which causes a little increase in vasopermeability, and some of these immune complexes just manage to get out of the blood into the interstitial fluid of the synovium, okay, and here they're going to activate sentinel cells in the synovium, okay, specifically in the synovium of synovial joints that are in the distal extremities. So it's thought that something must be special about the synovial joints of the distal extremities, such as the fingers or the feet. Okay, right. So what happens then is that these immune complexes bind to Fc gamma Rs on the surface of sentinel cells, and this activates the sentinel cells, which include dendritic cells, macrophages, and mast cells. And when activated, dendritic cells and macrophages start producing interleukin-1 and tumor necrosis factor alpha, and mast cells degranulate and release histamine. Okay, now histamine will diffuse over to the endothelial cells of the local blood vessels and cause type 1 activation, whereas interleukin-1 and tumor necrosis factor alpha will diffuse and cause type 2 activation. Now, both of these, however, overall lead to the same sort of thing, which is the acute inflammatory response. Okay, they lead to vasodilatation of the terminal arterioles, and for the capillaries and post-capillary venules, you get increased vascular permeability, and also you start recruiting leukocytes. So, what's going to happen? Well, fluid from the blood is now going to be able to move out of the bloodstream into the interstitial fluid of the synovium, okay? And some of this will also move then out of the synovium and into the synovial fluid. So you're going to get this inflammatory exudate, as it's called. So when you move fluid from the blood into the interstitial fluid out of these holes that you've now produced in the capillaries and the post-capillary venules, this is known as an inflammatory exudate. Okay, and this is going to cause swelling of the synovium and also of the synovial fluid. Okay, so this is going to lead to swelling. So you're going to get swelling of the joint, basically. Okay, it's also going to bring in a huge number of proteins from the blood, which are going to start off all sorts of things. Okay, and we'll talk about that in a moment. Right, you're also going to start recruiting leukocytes. Okay, so leukocyte recruitment. And two of the main types of leukocytes that you're going to recruit are neutrophils and also monocytes. Okay, so neutrophils are a weak type of phagocyte, basically. Okay, they're kind of like the pawns of the immune system. You bring them in because you've got a lot of them and you don't care if you lose a few. Okay, and then you also bring in a more powerful type of cell, so you're going to bring in macrophages. Okay, so you don't have macrophages within the blood, instead you have monocytes within the blood. Now monocytes will move out of the bloodstream into the synovium, and there they will differentiate mainly into macrophages, although they can differentiate into other things, as we'll see. Okay, right, so you're also going to get white blood cells coming out of the blood and going into the synovium, and these will also end up in the synovial fluid as well. So you get a huge inflammatory exudate which contributes to the swelling of the joint, but you're also going to get these leukocytes moving in which will also contribute to the swelling. Okay, so both of these also take up volume, and therefore they're going to lead to swelling as well. Now, let's turn our attention to this inflammatory exudate and some of the components which are within the inflammatory exudate. But just before we do that, let me give you another name for the acute inflammatory response occurring within a synovial joint. Okay, so it's referred to as synovitis. So when you get inflammation like this of the synovial joint, it's referred to as synovitis. Right, okay, so what actually happens in this synovitis? Well, you're getting this inflammatory exudate which is allowing fluid which contains proteins from the blood to leave the blood and come into firstly the interstitial fluid of the synovial membrane and then into the synovial fluid as well of the joint. Okay, now what's the significance of this? Well, one of the key things that is now going to be able to come out of the blood is you're going to bring, firstly, more immune complexes. Okay, so in the inflammatory exudate, you're going to bring in more immune complexes, so more of these anti-citrullonated fibrinogen antibody bound to citrullonated fibrinogen. Okay, so here are these preformed immune complexes. So you're going to bring in more and more of these, and these can then bind to the Fc gamma receptors on the surface of our sentinel cells and trigger positive feedback, basically. But you're also going to bring in all the other anti-citrullinated protein antibodies. Now, I said that some of these may well be directed to citrullinated proteins that are within the synovium or potentially within the synovial fluid. Okay, now some of these are now going to be able to come into the interstitial fluid of the synovium, and finally they're going to be able to find their antigen, basically. So previously they were just circulating within the blood, potentially for years and years and years, and they could not get access to the interstitial fluid of the synovial membrane. Okay, but now that you've got this synovitis occurring, loads of these antibody are going to end up in the interstitial fluid of the synovium, and there they will meet their antigen. Okay, so let's say we had some citrullinated protein within the synovium, and I want to stress that the citrullinated protein which is within the synovium is not known, basically, but we think there must be a citrullinated protein that is present within the synovial joints, basically. So some protein that is expressed within synovial joints that ends up being citrullinated, and then there is an antibody circulating in the blood which binds to this citrullinated protein in the synovial joints. But previously, in the pre-articular phase, it can't gain access to it, but now that you've got synovitis, it can get in, okay? And this means that you're going to get even more immune complexes being formed. Now, these immune complexes, again, these will bind to the Fc gamma Rs on the surface of the sentinel cells, and again, they can then lead to positive feedback in that way by activating the sentinel cells to release more pro-inflammatory mediators. But there are other ways that these immune complexes can also cause problems. Okay, they can also interact with complement proteins and activate what's known as the classical complement cascade. So let me talk you through this now. So we have got these immune complexes within the synovium. Okay, so they are within the synovium. Now we've also got increased vascular permeability. Okay, so other proteins are coming out of the blood and into the interstitial fluid of the synovial membrane. Okay, now some of these proteins that are in the blood that will now come into the interstitial fluid of the synovial membrane are complement proteins. Now, complement proteins are proteins that are produced by the liver and usually circulate in the bloodstream in an inactive form. However, when they see certain signs of pathogens, they can activate. Now, one of the signs of antigens is an immune complex, okay? So immune complexes can activate complement proteins via a complement pathway known as the classical complement pathway. Okay, so let me talk to you about the classical complement pathway. So the classical complement pathway is going to start with an immune complex. Okay, so I'll draw another immune complex down here. So here we have some antibody here, like so, and basically it needs to be bound to its antigen. Okay, so we've had this occur because we've got we've got two things that can lead to the activation of this. We've got these immune complexes that came from the blood, the citrulline-native fibrinogen with the anti-citrulline-native fibrinogen antibody, and we've also now got these other anti-citrulline-native protein antibodies, which is directed against some citrulline-native protein that's within the synovial joints that has now found its antigen and is therefore bound to it here. Okay, but we don't know what that antigen is. Okay, now what's going to happen is another protein complex is going to bind. So the C1 protein complex is going to bind. Now let me just show you the structure of the C1 protein complex. So C1 protein complexes consist of 10 separate proteins all put together. Okay, so I'll start with the bottom down here. Okay, like so. So, at the base down here, what you have is two C1R proteins. So here are the two C1R proteins. And then you also have two C1S proteins. So you have this structure which is made up of two C1R proteins and two C1S proteins. And I think to try and make this simpler, I'll colour this in. So here in red is the C1R protein, so both of them, and here in green this is the C1S proteins. Okay, so both of the C1S proteins. Right, and then bound onto this you then have 6 C1Q proteins. So let me put these here. So this is the structure of a C1Q protein. It has this fibrous portion and then this little head up here. Okay, and you'll have another one here and another one here, and then 3 more on this side. Okay, so this is the normal way that the C1 protein complex is denoted. So we have these 6 C1Q proteins. Okay, and now this thing is going to go and bind to the FC region, the fragment crystallizable of this antibody that's involved in this immune complex. Okay, and now what's going to happen is that this C1 complex, as it's called, and I should say that the entire thing is referred to as C1. Okay, so this is all C1. Right, it's going to bind there, and now what's going to happen is it's going to catalyze the breakdown of 2 other complement proteins. So let's have these 2 other complement proteins here. So here is complement protein 4, and here is complement protein 2. Okay, and what's going to now happen is that once the C1 protein complex is bound to the FC region of this antibody involved in the immune complex, it will now be activated to start breaking down these complement proteins. Okay, so it's going to break C4 down into 2 separate portions. Okay, so let me show this happening. So here is C4 having been broken down into these 2 separate portions. And I think I'll colour it in again. So I'll have C4 in orange here. Okay, and here is a small fragment of C4 known as C4A, and here is a big fragment of C4 known as C4B. Okay, so this is called C4B, and this then is called C4A. Okay, and then what can also happen is you can break down C2 into two fragments as well. So what will happen is once this C1 has bound to the Fc region of this antibody involved in the immune complex, it will start breaking down C4 into two portions and also C2 into two portions. So here is C2, and this is where there is a terrible piece of nomenclature. Okay, so there are two ways of naming the fragments of C2. The old way of naming C2 was to call the small fragment C2b and the big fragment C2a. So this is the old way of naming the fragments of C2. The new way, okay, the new way, someone involved in working in complement decided that a better way to do it was to name all of the small fragments, because complement proteins are all broken down like this. So the better way to do it was to name all of the small fragments A and the big fragments B. So we should swap it round. We should swap it round to this being C2A and this being C2B. So the new nomenclature is the exact opposite of the old nomenclature. Okay, and that is just horrendously confusing. Okay, so if you Google complement cascade, classical complement cascade, you'll get diagrams which blatantly contradict each other, basically. So some will say that it's C2A that is going to be important, and some will say that it's C2B that's important, and it is horrendously confusing until you're told the story that it used to be called C2A and now the big fragment is called C2B. So it's the big fragment which is important. Whether you want to call that C2A or C2B is up to you. I am going to use the old nomenclature because that's the one my lecturers used, so it's the one that's been drilled into me, basically. Now, what is then going to happen is that these C4b and C2As are going to assemble on glycoproteins that are on the surface of cells. So on the surface of cells you have glycoproteins. Okay, so I'm going to draw this here in pink. Okay, so here is a glycoprotein. Okay, and you're going to assemble. Firstly, the C4b is going to bind on top there, and I've just realised I've coloured in the glycoprotein in the same colour that I was showing C2, but never mind. So this is some glycoprotein on the surface of a cell. And then what will happen is the C4b, this is now currently floating around in the interstitial fluid after this enzyme structure has acted on it, that will bind to the surface of this glycoprotein. Okay, so here is the C4b here, so this is the big fragment that we got from C4, and now what's going to happen is the big fragment from C2 is going to assemble on top of that, and I'm going to call the big fragment of C2 C2A. Okay, so here is C2A assembled on the top of C4b. Now, once you've assembled this, this is going to act as something known as a C3 convertase, basically. So this structure here, which is often referred to as C4b2A, is a C3 convertase. So it's now an active enzyme, and it's going to work on the complement protein C3, which has also come in the inflammatory exudate. So you have a huge amount of C3 in the interstitial fluid. Okay? And this is now going to be broken down into two components. So a big fragment again, which is called C3b, and then a small fragment, which is known as C3a. Okay? Now, C3a is going to be very, very important. Okay? So we'll discuss that in a moment, however, because it's going to do something almost identical to another protein called C5a. So we'll come back to the C3a in a moment. Okay, so C3 has been split down into C3A and C3b, C3b and C3a. So C3b again is the big fragment, and C3a is the small fragment. Now what happens is that C3b can then bind onto another complement protein, okay, which again has come in the inflammatory exudate, which is C5. Okay, and this, once you've got C5 bound to C3, B rather, the C4b C2A can now work on C3b C5, and it will break it down into well, 3 separate proteins. Firstly, you'll regenerate the C3b, and then you'll break C5 down into a big fragment, which is C5b, and then a teeny little fragment here, which is C5a. Okay, now we won't take this any further. This does go further. The story doesn't stop there. You can start to assemble membrane attack complexes, but we've gone far enough, basically. C3a and C5a is what we were after. Okay, these are what are known as anaphylotoxins. Okay, and both of them have receptors on the surface of mast cells, which can activate mast cells. So when you start producing C3a and C5a, they will go back to mast cells. They will bind to either the C3a or the C5a receptor, okay, and that will trigger the activation of mast cells and therefore the release of histamine. So this is another positive feedback loop where the formation of the inflammatory exudate is triggering more inflammation basically, and more inflammatory exudate production.